concept of critical probing depth by Lindy. As you see, this paper has been published in 1982, pretty old classic paper, but a very interesting concept. And this study has been done in Foresight Dental Center or Foresight Lab in Boston. If you're not familiar with that, most of the famous classic papers in periodontology regarding bacteria and red complex, yellow complex, green complex, all those famous Sokransky studies are from this lab. So this study is a split mouth design, randomly assigned right and left side of the patient that has been diagnosed with periodontitis. Of course, the older classification, not the one that we use with the staging and grading, but this patient has been diagnosed with the moderate or severe periodontal disease and has been referred to this people for like treatment. So randomly assigned right or left side of the mouth for either modified Whitman flap or scaling and root planning. If you're not familiar with the modified Whitman flap, when we move on with the next lectures in this semester, you will know what is the difference between different flaps. So I highly recommend come back to this video if you're watching it now and you don't really know what is modified Whitman flap. Come back and watch it after you're familiar with different type of flaps and different surgical procedures in perio. I put a screenshot of just a random charting to have and like some sort of like reference point of looking at the charting and what does it mean to have this different probing depth. So as you see in facial side, I have, and this patient with periodontal disease, I have 6 4mm probing, 10mm probing in some areas of 2 and 3. You're looking at the lingual side of the teeth, you have 5 7mm, you have also 3mm, and you have 9mm. So it's a combination of like deeper probing depth and like shallower. So how would you address that, or does it matter? Or if patient is a periodontitis patient, would you just get your instrument and a scale and root plan everywhere, or you need to think about each spot and think about like, if I have 3mm probing, do I need to do root planning, or I just make sure that there is no subgingival calculus or plaque? That's all about this critical probing depth. So how did they determine this nicely designed study, old study? You see here the result of it has been demonstrated in this graph, and the vertical axis is the clinical attachment gain if it is above this horizontal axis or x-axis, and if it's below, it means this patient or that specific spot lost clinical attachment. So I recorded this separate video for you because it was just this concept and evaluation of all of this graphs are a little bit complicated, so I want you to spend more time and understand it. So when you understand what these people wanted to achieve out of all of these measurements, it will be very easy for you while you're treating patient when they come in with different probing depth and they're still like periodontitis patient. So here you see that they divided the incisors, premolar and molar. So, and you see I have, on the x-axis, I have the initial probing depth. So focus on this. The y-axis is the clinical attachment, either gain or loss, and the horizontal or x-axis is the initial probing depth that they have. And you have two lines that they cross the x-axis as the modified Whitman flap or scaling and root planning. We are going to focus now on the on this orange line, which is only scaling and root planning. Forget about the modified Whitman flap. You see that this line crosses the horizontal axis in a specific point. What does it mean? It means if you have incisor tooth and your initial probing depth is somewhere between 2 and 3, or it is less than 2.7, then if you scale and root plane that side, you will lose clinker attachment. You see, like this line, if it is below, if it's less than 2.7, you will lose clinker attachment. If it's more than 2.7, you probably will gain some attachment, and the deeper the probing depth, the more attachment gain you have. If you have 8 millimeter of probing in the initial examination and you do scaling and root planning, you will gain around 1.5 millimeter of clinker attachment. Okay, let's look at premolars. For premolars, this cutoff is 2.5. If I have 2.5, less than 2.5 millimeter probing depth for premolars, and I try to do root planning and remove the attachment and PDL and technically some cementum, then I will lose clinker attachment, which is common sense because you have attachment apparatus. If there is no calculus and there is no plaque there, and you try to use your instrument, go subgingival and remove it, so you're going to remove the attached PDL or Sharpie's fiber, so you will create some recession or clinker attachment. Okay, so follow this orange line here. If I have 8 millimeter initial probing depth, I will gain around 2 millimeter of clinker attachment after healing. The same thing for molars. For molars, this cutoff is 3.5. If you have a molar tooth with 3.5 millimeter or less than 3.5 millimeter probing, and you try to root plane and remove the attachment apparatus, you will lose clinker attachment based on this study. So what does it say? If you look at all of these numbers, you should be very careful about the incisor and premolars. If you have healthy like sulcus or probing depth of less than like 3 millimeter, usually you shouldn't be root planning that one, because based on Linda's study, you're gonna lose attachment. So to round it up, if you have 3 millimeter or less, please do not root plane. Remove the subgingival calculus and you just scale it. You take out the calculus. You do not attempt to remove everything from the root surface. And for molars, it leans more closer to 4, so it's 3.5, like 3.5 millimeter of probing depth. You don't want to root plane. Okay, so now we are going to talk about surgery. So is this any specific probing depth that you would gain some attachment by doing modified Whitman flap? I put a note here that this study is modified Whitman flap. When you're getting familiar with the different surgical techniques, it's not a resective surgery. Modified Whitman flap, you just gain access. Basically, you open a flap, gain access, and put back the flap. And we talk about that in much more detail in other lectures. So look at this graph again. Now we are focusing on the line which is for modified Whitman flap. For incisors, 4.1 is the cutoff. If I have probing depth of 4 millimeter for an incisor tooth, let's say here, if I raise the flap and try to clean and like debride the root surface, most probably I'm going to lose some attachment. Make sense? Okay. The same thing for premolars. This cutoff is 4.7. So let's say I have this number 5, I have 4 millimeter. Do I need to raise a flap in that specific site? Well, based on this study, I'm going to lose attachment. However, then I have 6 millimeter here. Then you will decide if you can handle it with scaling that side, then you would rather doing that instead of raising a flap. But this 9 millimeter is completely different story, because if I have 9 millimeter for incisors, modified Whitman flap will help me to gain attachment. Going to molars. For molars, the cutoff for surgery is 4.1. So if I Have probing depth of 4 or less than 4, no need for surgery. Based on this, you actually will create clinical attachment loss if you raise a flap for molars that they have 4 mm of probing depth. And try to debride the root, because modified Whitman flap is about raising the flap and debriding or cleaning the root surface. Now I want you to look at this. This is very, very interesting concept that I want you to watch it like maybe 2-3 times this short video, so this one stays in your memory. So we talked about modified Whitman flap and scaling and root planning separately. Now you look at the same graph and you see there is a specific spot or probing depth that modified Whitman flap will result in gain of clinical attachment more than scaling and root planning. This is the critical point. So if I have an incisor with 6 mm of probing depth, based on Lindy's study, I'm good with scaling and root planning because modified Whitman flap will not give me more clinical attachment gain. However, if this one goes around 6.5, 7, 8 mm, then there is a slightly more improvement of clinical attachment if I raise a flap and debride the root. Look at this about molars. In molars, the deviation of these two lines when we are going to the deeper probing depth is much more prominent than incisor and premolars. This is why, generally speaking, periodontists leaning more towards doing surgery for posterior teeth. I'm talking about debridement. I'm not talking about regeneration. Okay, just clarify this. We are leaning more towards doing the debridement or classic periodontal surgeries to for access to the root and clean it. Mostly about molars. About premolars and an incisor, we try to do it non-surgical because there should be a very deep probing that you see this difference. I'm going to explain again for molars, just to be clear about that. I have modified Whitman flap, this line, and I have scaling and root planning. If my probing depth is 4.5 around molars, I do not, 4.5 or less than 4.5, I do not get any, there's no advantage of doing modified Whitman flap because I don't gain more of clinical attachment. However, these two lines deviate way more when I get to 7 mm and 6 mm. So if I have 7 mm around the molars, it looks like I gain more clinical attachment. So patient will benefit more of periodontal surgical treatment for posterior teeth with deeper probing than anterior teeth. Okay, so there's the same graph. This graph has been kind of like redone or like redesigned again based on the original paper of Lindy, but this one is from Lindy's book, it's not from the paper. So the critical probing depth is the level of the pocket depth below which clinical attachment loss would occur as a result of the treatment procedures performed. Kind of like putting nicely together the thing that we were talking about. And be careful about the scaling and root planning of a healthy periodontium. Healthy periodontium, patient can have subgingival calculus and patient is gingivitis. Please don't forget that. I'm not saying that you should not be scaling subgingivally if you have calculus. You should remove calculus no matter what. But you are not trying to instrument the root surface and scrape everything off of the root surface. So periodontal flap, generally just to round up these numbers, periodontal flap for probing depth of less than 4 mm may cause a loss of attachment. So look at these two x-rays or radiograph. Based on the distance between the bone and the CEJ of this tooth, the incisor, it looks like this patient doesn't have a bone loss, but I do have a calculus. So I do try to remove this calculus by chipping it off and making sure that it is smooth, but I'm not root planning. I'm not getting my sharp instrument and scrape everything off of the root. However, for this molar, it's different. You see that I have bone loss, I have calculus. Because the side, I'm not sure about the probing depth, but if probing depth is like 6-7 millimeter, I get my instrument, I anesthetize a patient, and I remove the calculus, and I plane the root surface, a scraping sound, then I remove everything all the way close to the bone. That's the difference between these two. I put a small part of the abstract of this paper, just pointing out a few things, and I want you to think about it all. Every time that you have some information, some numbers, you need to be smart and know, like, okay, what was the design of the study? Like, how many patients they happen in this study? Am I just trusting it because it looks nice, or is actually like truly based on evidence? Lindy's paper is well known, well documented. We quote it all the time. I'm not questioning this specific paper, but I want you to know that this design of this study is only 15 patients, so it's relatively small sample size. In this paper, 6 months considered initial healing time. So we do 1 month eval, and then like we decide based on that, and we say like at this time your soft tissue is healed. But this is a little bit different design. So 6 months considered initial healing, and the maintenance has been done every 2 weeks for 6 months, which we do not do in everyday practice. Maybe there are people that do that, but it's not practical for a lot of dental settings that to do a maintenance every 2 weeks for a patient. And then after, they did every 3 months maintenance, which we usually do. And then last day data was collected 2 years after the treatment, so 24 months. I hope you enjoyed this presentation. Please go back and check it more after you're familiar with the different designs and different flaps and perio.